first case, as you can see, is a large biopsy. It might have been maybe done by incision technique or maybe punch, and they kind of bisected it or trisected it. So low magnification, it's got kind of a pale morphology. So we're not sure if it's inflammatory neoplastic low power. Certainly doesn't look like a lymphocytic process, like a lymphoid lesion, something like that. And given the large size of the biopsy, you think, well, maybe it's going to be a neoplastic lesion. And, unfortunately, when we get, we like to use criteria, breadth, symmetry, circumscription, that sort of thing. If it's a big lesion, you can't use all of those criteria because it's too big to determine whether the whole lesion is symmetrical or whatever. So you kind of have to use other criteria when you're dealing with that. But you can see now it does look more like a neoplastic process. And we always ask ourselves whether we think it's epithelial or non-epithelial. I don't see things here at this power that look like the epidermis, for example. I don't see any adnexal structure. So I would think this very well might be a non-epithelial neoplasm. And we talk about non-epithelial. There's really three main ones. So, dermatopathology for dermatology residents, kind of KISS, keep it simple, stupid sort of thing. You don't want to really get into super esoteric sort of things. The board's not going to expect you to know all the bizarre soft tissue tumors and all that sort of thing. They want you to be able to define the 3 to 4 most common spindle cell lesions. And we've talked about this many times, but mainly muscle, fibrohistiocytic, and neural. Those are the three main ones that you're going to look for. And, there's really not a gazillion differential diagnoses that you need to have when you're determining those three. And so as you go to higher magnification, we do see that it is spindle in nature. And we look at the cells and we see if they look more kind of blunt, like cigars in a way. Those are more characteristic of muscle lesions. A couple other things that can help you if you're dealing with a muscle lesion. If you see these kind of large fascicles like this, large fascicles that kind of look like they're both cut vertically and horizontally, they're cross section as well as longitudinally section. That's far more common with muscle, in my experience. So this would favor just looking at it without even really doing any stains or looking at even higher magnification. I would say, it's got these really large fascicles, if you will. They're not really interweaving like the fascicles of the dermatofibrocercum protuberans, for example. You don't see that storiform pattern. You see these sort of, you can imagine these are muscle fibers, if you will, that are cut both vertically and horizontally, cross section and longitudinally. And that's very, if you're thinking you would take a piece of meat that you eat at the next steakhouse, if you took that and looked at it under the microscope, you'd see something sort of like this. Now that's usually skeletal muscle, but it would look something analogous to this. The other thing that you can sort of tell with muscle is this kind of tends to have more of an eosinophilic cytoplasm, like you can see here. And it often has these little sort of vacuoles in here as well. That's more characteristic of muscle, smooth muscle, than it is neural or fibrohistiocytic. So this would strongly favor a muscle neoplasm. And we're dealing with muscle neoplasms in dermatopathology. There's really two. You're dealing with a leiomyoma or leiomyosarcoma, or sometimes you see atypical leiomyomas, but that's a more sophisticated sort of thing that you don't really need to worry yourselves about too much. The board's going to show you something. They're going to show you either benign or malignant. And then, of course, there's the angioleiomyoma versus the piloleiomyoma. And they might ask you about sort of the syndromes that can be associated with the multiple piloleiomas. Reed syndrome, for example, that's sort of tied into uratory with microsatellite instability. So make sure you know that. But this is an example of a smooth muscle neoplasm. And you can see that the cells look pleomorphic. They're atypical here. They're large. These nuclei are large. Here's a mitotic figure. And you start scrolling around and you might see multiple mitotic figures. And so when you see something like this, and we can't assess the breadth, symmetry, circumscription, but we can look and see that it's asymmetrical. It's got areas that are more cellular and more atypical in some zones. In other zones, it looks more bland and not really as atypical. That's a sign of asymmetry. So that, in this case, plus the cytology, would favor a leiomyosarcoma, not a leiomyoma. So again, those are going to be the kind of things you're going to be looking for. You look for mitoses, you look for atypical cells, pleomorphic cells, and asymmetry when you've got a relatively large biopsy with soft tissue lesion like this. So you can see this probably was biopsy before. There's kind of a scar up at the top. They probably did a shave biopsy, maybe got back a diagnosis of like an atypical lesion, and then went back and took a bigger biopsy. And so this is leiomyosarcoma. If you're going to stain this, obviously smooth muscle actin, Desmond can also be used. We usually just use smooth muscle actin. You don't really need both. If you're staining for fibrohistiocytic differentiation, factor 13A, that's classically seen in dermatofibroma, for example. CD68, which stains histiocytes. And then for neural, obviously SOX10, S100 protein are the major stains that we use there. So leiomyosarcoma, and if you get one on the exam, it's probably going to be something like that. Okay, now we have a punch biopsy, much smaller lesion. And we'll look at this piece over here. And see a low magnification. The epidermis is normal. The upper part of the dermis is normal. There's something going on down here in the lower part of the dermis. And at low magnification, you can see that there seem to be these little ring-like structures. If you can appreciate that. You see there's some lymphocytes, but there are also some pale cells here. And so when I see something like this at low power, immediately I think that this could be probably a granulomatous dermatitis, because it's got these pale histiocyte cells in here. Pale cells in low magnification, usually histiocytes. And when I see the ring-like morphology, I think about one of the palisaded granulomatous dermatitis. And just like we had with the three major spindle cell lesions, we've got the three main types of palisaded granulomatous dermatitis. And so again, keep it simple. We don't want to get into something that's really super esoteric. So annulare, necrobiosis lipoidica diabeticorum, and rheumatoid nodule. Those are the three main palisaded granulomatous dermatitis. And we talk about how you distinguish among those. There's a couple of different ways. For necrobiosis, the first way that is sort of classically taught is, well, what's in the center of the palisade? So let's take a look at this palisade. And if it's mucin, mostly in the center of the palisade, we obviously think of granuloma annulare. If it's fibrin, we think of rheumatoid nodule. And if it's degenerated collagen, we think of necrobiosis lipoidica. And that works pretty well in most of the cases. Now, there are some exceptions to the rule. We'll often see a case of rheumatoid nodule where you may get some mucin in the center of the palisade. We may see some little bit of mucin, maybe a little bit of fibrin and necrobiosis lipoidica. So there's a couple of other things that can help you to distinguish among the three. If you're looking at necrobiosis lipoidica, it tends to have what we call the so-called layer cake type of pattern of inflammatory infiltrate. So you see like histiocytes and then degenerated collagen, and another layer of histiocytes and degenerated collagen. So it looks a little bit different. It's more of a diffuse process with palisaded granulomas with the degenerated collagen going sort of almost from top to bottom and side to side. So that's the classic pattern of NLD when you see that histologically at low magnification. GA, when you've got this pattern here, where you've got this nice little rings with the mucin, the rings are usually relatively discrete. That's classic for some forms of GA. Now, there's the so-called interstitial form of GA that can be more diffuse, but even that pattern doesn't have the degenerated collagen and the density and diffuseness of the process of necrobiosis lipoidica. It's usually just kind of present focally in the center of the dermis. It's scattered. It's not really as dense and diffuse as you see with necrobiosis lipoidica. And then rheumatoid nodule, usually when you biopsy those, it's usually a large nodular lesion. It's not usually something where you do a punch biopsy and you get 2 or 3 small little annular-like rings with histiocytes in this palisaded pattern. It's usually a fairly large nodular aggregation with multiple large areas of the palisaded granulomas with the pink fibrin. So basically, the overall pattern of the inflammation looks different also, in addition to what's in the center of the palisade. So you can use both of those to help you make the diagnosis. So here, we've got a nice palisaded granuloma with this bluish gray material in the center of the palisade. This is a classic example of granuloma annulare. And what's interesting about this one is that it's more of a deeper GA. It's involving the mid to lower reticular dermis. And it's also near volar skin. and it may have come from a young person. And this actually is what we see when we see so-called subcutaneous GA. Now, that's a misnomer, as you can see, because it's involving the dermis primarily. A lot of times we see things that we feel them, they feel deep, and we say, boy, that feels like it's subcutaneous, it's beneath the dermis and whatnot. You biopsy it, it's actually involving the dermis itself. It just feels like it's deep because it's not involving the epidermis or the upper part of the dermis. So this is what we call subcutaneous GA, but it's not even getting into the fat. It's really mostly in the dermis, and these usually present as these sort of relatively deep looking plaques or nodules, often on areas near acral skin. Achilles tendon area, for example, is a good location for this, and they're often seen in kids. And so we call it subcutaneous GA, but it's really not subcutaneous GA. So hopefully that's helpful. Again, you don't have to become a soft tissue pathologist. One of the things that we always talk about in the differential diagnosis of this is epithelioid sarcoma. It's something to remember and think about. But if you just kind of know the things I just told you right there from the standpoint of the dermatopathology part of the board examination, that's really what you need to know. Okay, different ball game here. And we've got a shaved biopsy of what was obviously a little dome-shaped papule. Low magnification, you can see that it's a neoplasm, and it's an epithelial neoplasm. What kind of epithelium? It's very blue. So we say, well, could it be, things that are blue in the skin at low magnification? You think of things like lymphoid, neuroendocrine. Probably the most common is germinative epithelium, basaloid epithelium, especially of the follicle. Of course, we know that the most common cancer of man is basal cell carcinoma, which is a neoplasm that's recapitulating follicular differentiation. So the most common of the blue lesions that we see in dermatopathology are basal cell carcinomas or basaloid lesions, or follicular-based lesions. Those are the most common. Other things that can do it are some of the adnexal neoplasms, ecrine, apocrine. Those can be blue. So just remember those also. But the most common is going to be follicular and basaloid. And here we've got these nice little individual aggregations of these basaloid cells. And if you notice, one thing that's kind of interesting about this lesion, it's got a very, very prominent stroma with a lot of cells in it. It's also got clefts between the epithelium and the stroma. And one clue to the diagnosis of basal cell carcinoma itself is clefting between the epithelium and the stroma. Now, there's a difference between a criterion for diagnosis and a clue to the diagnosis. So a criterion, these are the features of the lesion that you use put together to make a definitive diagnosis. Those are things like you look at the cell type, breadth, symmetry, circumscription, those kind of things. Those are the criteria that we use to decide whether something's benign or malignant in the differentiation. A clue is something that's helpful if it's present, but it's not something that's required for the diagnosis. You don't have to have clefts to make a diagnosis of a basal cell carcinoma, and you can have other lesions that have clefts surrounding them that are not basal cell carcinoma. But the reason that you get clefts with a basal cell carcinoma is because of the stroma has more of a fibromucinous quality to it, and it's no longer really the same type of stroma that you see in the bulb of a hair papilla. That's or a peri-adnexal and adventitial stroma. It's a little bit different, and it's a neoplastic stroma. So it doesn't have the same adhesion, if you will, to the epithelium that it normally did if it were not a cancer. So here it's still got a little of the adhesion, and here it's kind of lost it. And this is actually something that is present in vivo. If you do confocal microscopy of a basal cell carcinoma, you'll actually see these clefts in the person. It's not just a histologic artifact, which is interesting. So when you see that, it's a clue to basal cell, you see it. But if you just saw this lesion up here, you say, well, gosh, that doesn't look like a typical basal cell. It doesn't have any clefting here at all. Does have the peripheral palisading of the nuclei, but it sure doesn't have any clefts. So don't just say, well, just because it doesn't have that it can't be a basal cell carcinoma. But what's interesting about this lesion is that this looks a little bit more like a primitive follicle lesion. And it's kind of got a trichoblastic morphology to it. So we talk about primitive follicular things. Another way to call those is trichoblast. And if you look at this little area here, this looks like the papilla of a hair bulb right here. So what this is a lesion that's got both trichoblastic features. If you just had this alone, you might call it a trichoblastoma, but then it's got other areas that look pretty much like a basal cell carcinoma. And we encounter this lesion every now and then. So this is what we call a trichoblastic basal cell carcinoma. These lesions actually are often present clinically as cysts. They're often seen in sun-protected areas. They may be seen in dark-skinned individuals. So we'll often see somebody that maybe, say, an African-American patient comes in with something in the axilla, is thought to be a cyst. Clinician biopsies it, and lo and behold, it looks like this. And it's a variant of a basal cell carcinoma that's got this trichoblastic morphology to it. So you could possibly encounter something like this on the board. It's a little bit esoteric. I doubt that they would show this to you, but just be aware that occasionally you'll get a lesion that has overlap between a basal cell carcinoma and a trichoblastoma. Dr. Ackerman, in his when he started kind of analyzing these lesions in the later part of his career, he decided that really all basal cell carcinomas should be called trichoblastomas because they were follicular lesions and they were primitive and whatnot. I'm not sure that he really ever got too many people that agreed with that, but this is an example that it does show features both of trichoblastic differentiation and basal cell carcinoma features. So we usually call these lesions basal cells and recommend that they get removed. They usually have a lower grade biologic behavior than, say, like a more morphiiform basal cell or a classic nodular basal cell on sun-damaged skin. These probably are not induced by the sun because they're in an area where there's really no sun damage. Okay. Small shave biopsy. And sometimes, unfortunately, we have to show you these biopsies like this just because the clinician has taken this and it's not really, it's a rare disease or an unusual condition and they haven't taken an optimal biopsy, but we want to teach you the findings that you're supposed to see anyway. So we can't really evaluate a lot of the histologic criteria. We can't assess whether this is superficial and deep. We just can't see a lot of things, but we can see some things. So whenever you're faced with a suboptimal biopsy, which we're faced with in this laboratory every day, hundreds of times, you have to have the ability to apply the criteria that you can apply in this situation. So the first thing we would ask ourselves, inflammatory neoplastic, and in this case, it happens to be inflammatory. And so obviously the next step is, well, what pattern are we dealing with? And you can see it's pretty sparse, superficial perivascular infiltrate, but notice that the dermis is abnormal here. Even though it's not great, you can see that this dermis does not have normal architecture. Over here, it looks pretty good. You can see the collagen bundles, some clefts between them. Here we have no clefts. And we start seeing one of the 9 patterns of inflammatory skin disease that a lot of people kind of forget because it doesn't always have a lot of inflammation in it. But fibrosing and sclerosing is one of the 9 patterns of inflammatory skin diseases. And the definition of sclerosis histologically is homogenization of the collagen bundles and a decrease in the number of fibroblasts. And you can see that's what we see here. In some areas, there's basically no fibroblast. There's a few, but there's definitely a decrease. And you can see that the collagen bundles here are homogenized. And basically, here you've got some clefts between them. Here you've got no clefts. It's almost like the collagen's been stuck in a wearing blender and poured over the skin, and it's all just homogenized there. That's a way to think of it. It's pink. And then up here, you can see that it's even involving the papillary dermis. And there also is effacement of the epidermal reshift here. Okay. So we got a sclerosing process. And then let's take a look at the other half of the specimen. And this is a good lesson for you as well. You always want to look at every piece of tissue that's given to you on an examination. Okay. So if they give you a slide that's got 3, 4 pieces on there, you want to look at each and every one of those pieces. Don't just look at one, or you'll miss the diagnosis. So let's say you decide you're going to look at one. So, well, okay, I recognize this as sclerosis, and multiple choice. You look down there and you see morphia, and you just tick it off, and you're happy. Let's go to the next case. I got that one right. Well, if you look at this other piece over here, guess what? You got a different pattern here. You've got no sclerosis. But what do you have here? You've got an interface dermatitis. And we know that there are two types of interface dermatitis, vacuolar interface dermatitis and lichenoid interface dermatitis. And if you know your stuff and you're actually an ability to apply criteria, you have to obscure the interface and the lichenoid inflammatory infiltrate for it to really be interface dermatitis. So if it doesn't obscure the junction, if you just got some cells sitting down here and you got a sparing, maybe even a grin zone or whatever, you don't call that lichenoid. That is not lichenoid dermatitis. So it's got to obscure the junction or it's not lichenoid. Well, here we've got vacuolar alteration. And if you look carefully, there are even some necrotic keratinocytes in here, and there's some overlying parakeratosis. Okay, so what diseases do we know where you get both interface vacuolar alteration and you get sclerotic collagen in the dermis? Is that characteristically seen with morphea? No, it is not. And occasionally you'll see morphea with features of lichen sclerosis etrophicus, but there you don't get vacuolar interface dermatitis. You get a band-like infiltrate of lymphocytes. You may get some lichenoid infiltrate in some cases, in some florid cases of kind of relatively early LSNA, but you will not get vacuolar alteration in LSNA. And when you get morphea with features of LSNA, you don't get vacuolar interface dermatitis. So where can you see this pattern? Well, some cases of lupus can give you dermal sclerosis. So that would be one thing in the differential diagnosis. But another situation that would be more likely is something like chronic graft versus host disease, because that can give you both of these patterns. The relatively acute form gives you a vacuolar interface dermatitis like this, with the individual necrotic keratinocytes, looks very much like possibly evolving erythema multiforme, or it can look like lupus, look like a vacuolar interface drug eruption. So it's fairly non-specific. So if you just had this alone, you wouldn't say, graft versus host disease, you'd put it in the differential. But when you couple these together, and this is probably, they wouldn't just give you this on the board examination, I think, like this, without some clues to kind of guide you in this general direction. This would be a scale of 1 to 10, about a 9 on difficulty without really any history. But at least you've seen it now and you've heard of it, and I want you to think about it. So if you see vacuolar alteration, vacuolar interface dermatitis, and then in another area you see sclerotic changes like this, you should think about graft versus host, because it gives you both of these patterns. Early vacuolar, later sclerotic. So this is a nice example of where you've got cutaneous graft versus host. It's got two different patterns, and I think this was possibly just one biopsy where they maybe showed this change in one area and then the vacuolar in another area, which is kind of interesting. Usually, and that's another teaching point, because we always talk about chronic is going to look like this. Well, sometimes you'll see both acute and chronic changes in the same patient, even though the disease may be present for a relatively short period of time or a relatively long period of time. And that's one of the reasons that using sort of things like chronicity and acuteness of a process for the name of a disease is flawed. So you'll hear people say, acute or subacute lupus erythematosus. Well, somebody can have a lesion of acute lupus erythematosus and have the disease for 50 years. Or they can have, chronic discoid LE lesions that look like DLE that come up relatively acutely. So it's not a great term. Same thing with pityriasis ligonoides. You get somebody that's got histologic changes that look like Mucke-Habermann disease, and somebody that may have had pityriasis ligonoides for 20 years. So it's not really good to think about diseases in terms of the time, the length they've been present and their histologic changes, because you can get changes that look like a relatively acute lesion and somebody's had the disease for a long time, and vice versa. So this is probably somebody that, and I don't know how long this guy's had it. I would suspect probably a fairly long period of time, but he's got changes of acute and chronic GVHD in the same slide. Could have even been the same lesion. Okay. So we have another shave biopsy, and again, hopefully you'll learn that we really don't like shave biopsies for inflammatory skin disease. I just decry them. Why not take a punch? I mean, everybody's busy, patients coming in, press for time, and just pull out your shave biopsy and do a little shave of it and hope you get a diagnosis. And sometimes you do, sometimes you don't. And if you don't, well, then you're gonna have to do, it's gonna take you longer than it would have taken you to do the punch biopsy, because the patient's got to come back in. You got to reset everything up, you got to do the biopsy again. You get an angry patient that has to be biopsied twice. They maybe complain, and also that adds a lot more time at the end of the day than if you just do the right thing from the beginning. So I'm not a fan of shave biopsies of inflammatory skin disease. Imagine most of you probably know that. But anyway, we've got a shave biopsy from volar skin. And again, we presume it's inflammatory. We don't see any neoplastic process here at low magnification. We've got something going on in the epidermis, and we've got some pale something or other going underneath the dermis here. And then we don't know anything about the inflammatory infiltrate because they just barely got into it. So, we see what seems to be some lymphocytes here. We don't know how deep this goes. We don't know if there's any vasculitis deep to this. We don't know, anything down here. This is all a mystery to us because they only decided to give us this. They said, well, we're only gonna allow you to look at the epidermis, basically. We're gonna, let's put you in a boxing ring with Muhammad Ali, and we're gonna tie at least one of the hands behind your back. So that's basically what they decided to do. So we have to basically go with what we've got here. So we got our magnification. All we can see is there's a little superficial perivascular lymphocyte infiltrate. We don't know much else about it here. We've got a higher magnification. We don't see any other cells like eosinophils or anything like that. We have a few blood vessels. We don't see any fibrin or any thrombosis of vessels, no vasculitis. But we do see some changes in the epidermis. And we've got this other finding here, which is prominent edema of the papillary dermis. And then we've got this other finding here that I want to point out to you, where you've got these little strands of cytoplasm from the keratinocytes here, coupled with the individual collagen strands of the papillary dermis here. You kind of got two strands. You got strands of the epithelium that are kind of being strung out here, like, silly putty, if you will, or chewing gum. And then you've got these little strands, almost like these little strings here that are kind of holding the epidermis up together. So it's almost like the epidermis is crying, please don't let me fly away. And the papillodermis is saying, well, I'm trying to hold on to you. I'm trying to not let you float off into the distance or whatever. And we call that reticular alteration. Reticular alteration. Reticular meaning kind of reticulated, like a net, if you will, strings, if you will. And that's actually characteristic when we see ballooning degeneration in papillodermal edema. But it's often seen with ballooning degeneration. We see that. So it suggests to us that something is going on both in the epidermis and in the dermis, in the papillodermis, when we get this. So it's kind of a combination of papillodermal edema plus edema of the individual keratinocytes. As we look at higher magnification, you see that there's some of these pink structures within the keratinocytes. You have to look at these really, really carefully. And these are not just necrotic keratinocytes, actually. When you see these little round structures with a little cleft around them, like here, here, and here, these are little intranuclear inclusions or intracytoplasmic inclusions, usually kind of intranuclear inclusions, and they actually go along with ballooning degeneration. And anytime you see it with viral induced ballooning degeneration. So these are viral products here. These are viral inclusion bodies in the epidermis, okay? And so when you see that, this is an example of a viral vesicular dermatitis on volar skin, and this was an example of hand, foot, and mouth disease, where they actually had they biopsied a little lancet-shaped blister on the skin and sent us a shave biopsy of it. Probably a touch sophisticated for you for the exam, but I wouldn't say out of the question of doing it. So I want you to be able to recognize this pattern as ballooning degeneration. This is intracellular edema, intracellular edema. This is the early viral change here, and then they get pink as time goes on. So this is not easy, but you're going to be a third year after you're going to finish 3 years of training. So you will have seen this before. So make sure whenever you see something like this, where there's ballooning degeneration, you look carefully for inclusions. And they had CMV on my exam years ago, which was fairly hard. you had to look carefully and you had to know where to look. You wouldn't look here for cytomegalovirus. Cytomegalovirus, you look down around the endothelial cells in the dermis. They actually had CMV on our exam. They had molluscum on our exam. They had herpes on our exam, and they had CMV. So they had 3 viral infections on the dermatopathology part of our exam, and that was, 40 some odd years ago, whatever. So if they can have it 40 years ago, they can sure as heck have it today. So just recognize, think ballooning, think virus. It doesn't mean virus every time. In fact, the next slide I'll show you is an example where it isn't virus. But when you see ballooning, think virus and look for the pink inclusions. So this is pink inclusions of Coxsackie virus here. Okay, they look similar. If I could go to even higher magnification and take one of these and transpose it adjacent to a molluscum body, they both look pink and they both look kind of similar. So when viruses cause these pink inclusions, they all kind of look the same, look pretty similar. It's a different morphology, different pattern, but they're always pink like this. So this is really helpful when you're diagnosing one of these conditions. Okay. This guy gets a better grade because they took a punch, thank goodness, which we like punch biopsies of inflammatory skin disease. And we're going to look at this one here. And this is nice because you're getting a little lesson today, a little mini theme here of ballooning degeneration. So now we can see the whole thing, right? Got a nice, excellent punch biopsy. We've got a superficial and mid to deep infiltrate. These cells are dark. They're going to be mostly lymphocytes. And then once again, we've got some pallor within the epidermis and possibly even in the papillary dermis here, kind of like we just had before. You've got the reticular alteration again here. See that? Strands of some of these epithelial cells here and the little papillary dermal strands of collagen kind of trying to pull it back up here. So once again, you've got some ballooning degeneration. Now, this time you don't have any intranuclear inclusions. You've got all sorts of necrotic keratinocytes here that are ballooned, but you don't have the little round inclusions that are discrete. This whole epidermis here is degenerating. Notice that that's different. No inclusions. So I want you to be able to recognize that. No inclusions here. And this also has got a superficial and deep infiltrate. Goes all the way down here near the subcutaneous fat. It's got a lot of lymphocytes. This one also has some eosinophils in it. So a little different pattern, but we can actually see the nature of the cells here. We don't see any vasculitis. We don't see anything else like that that's going to cause a change. So we would have a differential diagnosis here. But with the ballooning degeneration, one of the other things that can cause this is photodermatitis. Things like Hydroa Vacciniforme, juvenile springtime eruption. Those conditions will give you ballooning degeneration in the epidermis. And that's actually what this is in this case, interesting enough. This is Hydroa Vacciniforme. Now, this is a little bit too hard. They wouldn't show you this and expect you just to make this diagnosis, at random. If I saw this without any history, I couldn't make it at random either. I might look at it and come up with a different diagnosis and suggest that, given the fact there's some eosinophils here. I would also probably say, well, could this be some kind of an unusual phototoxic drug eruption? Could it be an unusual bug bite reaction? Because there are EOs. So I wouldn't just get this, cold. You'd have to have more information here. So don't expect that, gosh, how would I know this without any information? They're not going to ask you that. That's not fair. But if you know the pattern, the fact that you've got ballooning degeneration in the epidermis, you've got a superficial and deep infiltrate, which tends to be seen more commonly with photodermatitis. So let's say you get a photo-exacerbated drug eruption versus just a regular drug eruption. The photo-drug eruptions tend to give you more of a superficial and deep infiltrate versus a non-photo-exacerbated drug eruption. And that's because the UVA, which is the action spectrum of drug eruptions, the ultraviolet A, it penetrates deeper into the dermis, and it causes inflammation deeper. Most likely reason for that. That may be a little simplistic, but you can think about it that way. So the same condition, non-photo exacerbated, tends to be more superficial. If it's superficial and deep, think, maybe it's photo exacerbated also. But here we're dealing with Hydroa Vacciniforme, ballooning degeneration induced by sunlight, induced by ultraviolet light. So again, that's another cause of ballooning degeneration, the photo-related process. Now, there's one other thing I'll just mention about this that you may encounter, and this is sort of something that you just need to know. Doubt they would ask it on the board examination, but there is a form of cutaneous T-cell lymphoma that can give you a Hydroa Vacciniforme-like morphology clinically and histologically. You get ballooning degeneration like here, but instead of getting this pattern here, you get an obvious atypical T-cell lymphoma down in the dermis. And that's often seen in individuals of Hispanic descent, often seen in young individuals. Head and neck area, the ear is a common location for that. So that's just something that you need to know, put it in your encyclopedia of dermatology knowledge that you will encounter, but it's not Hydroa Vacciniforme, it's a Hydroa Vacciniforme-like cutaneous T-cell lymphoma. And it's also often related to Epstein-Barr virus infection. Okay. Next example here. Another nice inflammatory skin disease, excellent biopsy. We just love these kind of biopsies like this. And it's done well. They didn't crush it. I mean, it's just, this is a perfect A+ punch biopsy. And I'm glad they did this because this allows us to look at everything that we need to look at here. So what's the pattern that we see here? Well, notice that's involving virtually all of the dermis in this area right here. So if they had done a saucerization biopsy like here, everything would be involved. So this, and notice it's also got little nodular aggregations here. So this is a nice example of nodular and diffuse dermatitis. That's one of our 9 patterns, nodular and diffuse. And so when we see that, we ask ourselves, what is the cell type that we see in this nodular and diffuse inflammatory process? And at low magnification, say, well, there's some dark cells in here, so there's going to be some lymphocytes. But notice that there's also a whole lot of these pale cells in here. So obviously, whenever we see pale, I want you to be thinking histiocytes. And when we think of histiocyte predominance, we think of granulomatous dermatitis. And there's 5 types of granulomatous inflammation. There's suppurative granulomatous dermatitis, there's foreign body granulomatous dermatitis, there's sarcoidal, there's palisaded. So again, those are some of the, and then the main granulomatous dermatitis patterns. Here we see, and then tuberculoid is the other one, we see sarcoidal granulomatous dermatitis. Sarcoidal, right here. These are nice epithelioid sarcoidal granulomas. Okay, so this is this is right down the middle of the fairway for a board examination type questions. It's a beautiful biopsy. It's got classic features. It shows sarcoidal granulomatous dermatitis. They're going to expect you to be able to recognize that pretty quickly, and so they're going to make you sort of go down they're going to ask you what the differential diagnosis of something like this is. And so they're probably, you know, I'm not sure they would expect you to be able to say, look at this and say, just tell you immediately the differential, that you could tell this, say, from a sarcoidal foreign body granulomatous dermatitis. That really wouldn't be fair. But they might say something like, which disease is associated with this histologic pattern? And they might list sarcoid, they might list Crohn's disease, they might list syphilis, which can do it on occasion. They might list granuloma annulare, which would not usually give you this pattern. You know, they might list Mycosis and Rosenthal, you know, some of those kind of things. So they might expect you to know the various diseases that give you a sarcoidal granulomatous dermatitis pattern. They might put tuberculoid leprosy down. Does that give you this pattern? And the answer is yes, it does. And that's often confusing to residents. They say, well, tuberculoid, you think about it, a tuberculoid granulomatous histology, you know, with caseation degeneration, look like tuberculosis. Well, no, it doesn't. It gives you a sarcoidal granulomatous dermatitis pattern, because basically the opposite of the other granulomatous pattern you see in Hansen's disease is not sarcoidal. It's kind of a diffuse pattern, the lepromatous pattern, where you get all the foamy histiocytes that are filled with the organisms. When you get a very brisk inflammatory response in tuberculoid in Hansen's disease, it develops a tuberculoid a sarcoidal granulomatous histology, but it's called tuberculoid Hansen's disease because years ago it kind of looked more like tuberculosis when they had scattered lesions as opposed to diffuse Mycosis Hansen's disease. It really looked like tuberculosis. If somebody had that much TB back in the days before they had drugs for it, they wouldn't survive. They basically had miliary tuberculosis, or they'd have like a widespread, tuberculosis over their entire body and skin that just had such an overwhelming organism load they wouldn't live. So they had tuberculoid lesions like that with tuberculosis. I mean, they would have it, but they wouldn't have the diffuse Mycosis pattern with TB, and patients wouldn't survive. So they just called this tuberculoid Hansen's when histologically it looks like sarcoid under the microscope because they have a very prominent brisk reaction, and the reaction they get is this. They get these nice epithelial granulomas. Now the differential, you can tell usually tuberculoid Hansen's from sarcoid itself because Hansen's usually is centered mostly around neurovascular bundles. It hits the nerves primarily, and you don't usually get this diffuse sarcoidal pattern like you see here. So this is a classic example of sarcoid. And, you never know. They might ask you this and just expect you to recognize it and then get you to pick it out of a lineup of choices. But you should be able to recognize this as a classic example of sarcoidal granulomatous dermatitis. Beautiful example of it. Okay, this is an interesting one here as well that you're probably not going to see on the board examination, but it's one that we want you to be able to at least understand. So for the punch biopsy here, once again, we've got a fairly dense, diffuse infiltrate here, not just perivascular. It's not just involving only the areas around the blood vessels and adnexal structures. It's also fairly interstitial. And it's got lymphocytes here, but it's also got some pale cells here also. So once again, pale, think granulomatous. Histiocytes predominate, granulomatous inflammation. That's going to narrow your differential diagnosis down. You're not going to spend a lot of wasted time, thinking about spongiotic dermatitis and things like that. You're going to say, I'm going to be searching for an infectious disease. I'm going to look and see what the pattern of the granulomatous inflammation is. Is it a palisading granulomatous process? Is it sarcoidal like the last case? Is it more suppurative granulomatous? Might see that with something like a deep fungal infection, et cetera. If it got this a tuberculoid pattern, I'm going to look for maybe something like an AFB infection, something like that. So it's helpful to just narrow you down, and then you can kind of zoom in and make a specific diagnosis. So here we've again got a granulomatous inflammatory reaction. That's a little bit different than what we saw before. It doesn't look like the nice little rings that we saw with the case of GA that we saw earlier. It's obviously not sarcoidal here. It's got more of kind of this diffuse pattern, poorly organized histiocytic infiltrate here. And if you look up at the top, you'll also see it's got a little sparse superficial perivascular infiltrate with some lymphocytes. It's maybe got a little bit of involvement in the epidermis here. And this is a zebra that you are not going to get on the board, so don't worry about this one. But it's educational because we wanted to show it to you. And this is an example of granulomatous cutaneous T-cell lymphoma, granulomatous mycosis fungoides. And sometimes in MF, the patient's host reaction will be a granulomatous inflammatory infiltrate. You get histiocytes that come in and they start gobbling up the atypical lymphoid cells. And you can see, if you look carefully, some of these lymphoid cells are present within the cytoplasm of these histiocytes here. And if you look at cutaneous T-cell lymphoma with granulomatous inflammation, you'll usually see overlying evidence of at least patch stage MF. And this is a nice example of that, what we call eyeliner sign, if you will, where you get the individual lymphocytes lining up at the basal cell layer, a little bit of epidermotropism over here, maybe a little early protease collection. And then, so this is probably a little bit too difficult for them to show you this without some clues on the exam, but you can make the diagnosis here because of that, coupled with this granulomatous inflammation down here with these atypical lymphoid cells that are present within the cytoplasm of these histiocytes here. There's also some eosinophils in here, interestingly enough, and you do get eosinophils sometimes in mycosis fungoides. So that doesn't mean that it can't be MF if there are eosinophils. So this is a nice example of mycosis fungoides, where you had a granulomatous inflammatory reaction coming in, and patients that have this actually usually have a better prognosis than patients that don't have the granulomatous inflammatory infiltrate. It's their host is fighting off the MF as opposed to just letting the MF progress. Now, there's one other scenario where we get granulomatous inflammation in patients with cutaneous T-cell lymphoma, and usually these histiocytes come in, they develop these large multinucleated morphology with maybe 10 or 15 nuclei. They're not only engulfing the atypical lymphocytes, but they're also engulfing elastic fibers, sort of like what you see with, cutis laxa and some of these other conditions. And that's called granulomatous slack skin syndrome. And these patients get these large pendulous folds of skin, usually in the axilla and the groin. That's also a manifestation of cutaneous T-cell lymphoma that you can see. And it's a granulomatous reaction to MF that they also get these atrophic pendulous folds of skin. So make sure you at least know that entity and look it up and read about it. It's really impressive. If you ever see a patient with that, you'll never forget it. Okay. Another case here. And now we've got a shave biopsy. And now we're dealing with a neoplastic process. And you can imagine what this thing probably looked like. It either was something that might have been sessile and pedunculated, or it might have been something where they enucleated it. So one of those two possibilities. And at low magnification, you can see immediately it's got all this basophilic color. So we're going to say, well, this is going to be epithelial basophilic. And just like we talked about before with the trichoblastic basal cell, we're going to go down that same differential diagnostic pattern. Say, is it follicular? Is it adnexal? Is it possibly lymphoid? Is it possibly neuroendocrine? Sometimes melanocytic, but we're going to look at that when we get to higher magnification. Is it benign or malignant? Well, we're not sure at this power. It sort of looks like it may have been some kind of either something that was, like I said earlier, maybe it's pedunculated and they just kind of saucerized it. It seems like this may be the whole thing, but we're not sure. So we're going to probably have to use some ancillary criteria. We're going to have to see if they're mitotic figures, if there's necrosis en masse, pleomorphism, some of those things at higher magnification. So as we go to higher magnification, now we see it's got this glandular morphology. So we know now it's epithelial. That confirms that diagnosis. It's got a glandular morphology. So that's okay. We're going to take ourselves out of the basaloid category, no longer in the lymphoid category, no longer in the neuroendocrine category. Now we're in the adnexal category. And we think about adnexal neoplasms in dermatopathology. There's really only about 4 or 5 adnexal structures we need to concern ourselves with: follicles, sebaceous glands, apocrine glands, eccrine glands. That's pretty much it. And so we need to know how to distinguish those from one another. And when we're trying to look at a gland, we want to see, well, what are the cells that are comprising the gland? And if it's got a duct, for example, we want to see what's the lining of the duct. Well, you see a nice ductal-like structure over here. And if you look at higher magnification, it's got these little snouts of cytoplasm that are being pinched off at the surface. And when we see that, that's a classic example of apocrine differentiation. So we know we're now in the family of apocrine lesions. And there's not too many of those that you need to know about either. So for example, if it's a cyst-like lesion that's inverted, we think about so-called Hidradenoma Papilliferum. If it's a exophytic lesion that's on the scalp, we think of Syringocystadenoma Papilliferum. So those are basically the same lesion. One's sort of external and one's kind of internal. So you don't really need to worry too much about how to distinguish those from one another when you're looking at the actual structure and differentiation of the actual epithelium. Once you kind of look that it's papillated and it's apocrine, it's either one of those two. And if it's a cyst-like lesion, often in the genital area, it's got a glistening red pyogenic granuloma-like surface to it, it's got plasma cells in the center, well, then it's a classic example of the Hidradenoma Papilliferum, and that's actually what this is. If it were on the surface of a warty lesion, often associated with nevus sebaceous, well, then it's Syringocystanoma papilliferum. So that's basically all you need to know about this lesion. It's benign, doesn't have any atypical cells in it, so it's a good higher magnification. We see no mitotic figures. All these cells are very nice. There's no pleomorphism. There's no anaplasia. Everything looks the same. There's no abnormal differentiation. No mitotic figures are atypical. You got the nice apocrine differentiation here. So this is a classic example of a Hidradenoma Papilliferum. And they could show you this on the exam. You know, it's fair. They do like to show some adnexal neoplasms on there every now and then. Okay, here we've got a punch biopsy. From what part of the body are we on? We're in a hair-bearing area. It's either going to be the face, because it's got lots of large sebaceous lobules, or it's going to be on the scalp in somebody that's bald. And this time I think it's more likely going to be on the face, but lots of sun damage up here. So and there's really no terminal follicles. Usually if somebody's bald, they might have one residual terminal hair follicle. This is almost certainly on the face. Is it an inflammatory or neoplastic process? Well, we don't see any neoplasm. We see a lot of sebaceous lobules. But what do we see? Well, we see this white space here beneath the epidermis. And we see an inflammatory infiltrative lymphocytes here. Maybe there might be some other cells in there. But we've got a space between the epidermis and the dermis. Now, is that a real space or a fake space? You know, you get clefting histologically a lot of times. Let's say you get somebody that's got stasis dermatitis and their skin just doesn't adhere to their underlying stasis altered skin as well. You do a biopsy of that and the epidermis separates from the dermis because it just isn't glued down as much as it should be, and it's not really a real blister. But here, we've got something in the space. We've got blood cells in there. We've got some lymphocytes. So this is true. This is not a cleft. This is a subepidermal blister. A subepidermal blister. So this puts us in the category of the subepidermal blistering diseases, which is one of the 9 patterns of inflammatory skin disease. And now look how deep this blister goes. It's going way down adjacent to the infundibulum and the isthmus here of the follicle, even further down. That's not an artifact. Whenever you see involvement of hair follicles and periadnexal structures like that, that's a real honest-to-goodness process. It's not something that's just seen in the laboratory. And the other thing you look for is if there's something in the blister space. There's serum, there's red cells, there's inflammation. So this is a subepidermal blistering dermatitis. So the next step is ask yourself what kind of inflammatory cells are in the infiltrate. Well, here we've got mostly lymphocytes, but we've also got some eosinophils in here. So when you see lymphocytes and eosinophils, one of the things you think about is bullous pemphigoid. You can also see lymphs and eos and epidermolysis bullosa acquisita. There's several different patterns of EDA. There's one that's got basically no inflammation. There's one that's got neutrophils. There's one that's got lymphs and eos. There's one that really looks kind of like epidermolysis bullosa in the mechanobullous form. So this could be bullous pemphigoid. But is the face a common location for bullous pemphigoid? Not really. And is there another finding here that we see that we don't usually see with bullous pemphigoid? We've got this scar here. We've got fibrosis, an increase in the number of fibroblasts. So this is a subepidermal blistering disease with scarring. And what diagnosis do we know that gives you this pattern? This is a nice example of cicatricial pemphigoid. And there's 2 forms of cicatricial pemphigoid. There's the mucosal form, and then there's the non-mucosal form, the so-called Brunsting-Perry form of cicatricial pemphigoid that occurs in usually older individuals, the scalp, the face, common location for that. And this is a fantastic, beautiful example of that disease. You just are never going to see it any better than this. So if they show you this on the board examination, it's going to be something like this. A gorgeous, classic example of cicatricial pemphigoid. So subepidermal blister, lymphs and eos, maybe relatively limited inflammation, may get some polys, but with a scar on a sun-damaged skin area, face or scalp, you want to think of cicatricial pemphigoid. Now, the interesting thing about cicatricial pemphigoid is that you'd think it should be positive with immunofluorescence, and it should be. But in some cases, 40 to 50%, it may be artifactually negative. The indirect may be positive, but the direct may be negative. And I'm not sure why that is. Maybe the scar tissue degenerates the immunoreactants, but we often get false negative results in CP. So you may just have to correlate that with the clinical finding. So let's do one more in the last couple of moments that we've got here together. And we've got a shave or an enucleation biopsy, and we've got this kind of interesting phenomenon out here that looks like these dark bluish purple structures, and this happens to be bone ossification. So is this osteomycutis? And you look down at your list of choices, and yeah, it's there. So you click it off and go down to the next one. You feel comfortable. You've maybe gotten the diagnosis correct, and you're ready to move on. Well, once again, don't do that. Look at the whole picture. So yes, there is osteomycutis here. There's ossification, but there's this other process going on, and you've got this neoplasm that basically enucleated out here, and it's got these little small duct-like structures of epithelium with this background pink collagen, and in some areas, you're going to see mucin and some cartilage-like change over here, cartilaginous metaplasia. So this is an example, a mixed tumor chondroid syringoma is the other name for that. And chondroid syringoma can undergo ossification. So here, the pink is where the cartilage is turning into osteoid, and the osteoid has gone on ahead in these other areas and turned into bone. So you've got an ossifying chondroid syringoma, an ossifying mixed tumor of the skin. So don't just see this and hop to a diagnosis. You don't want to hip shoot. People that shoot from the hip often end up shooting themselves in the foot. So don't hip shoot these things. You want to work through them systematically, do this approach, type of biopsy, inflammatory neoplastic, benign or malignant if it's neoplastic, if it's inflammatory, one of the 9 patterns. What kind of differentiation are we exhibiting? Is it one type? Is it multiple types? Understand that if you get something like a mixed tumor, it can undergo ossification, and it can develop osteoid in the lesion also. So mixed tumor of the skin with ossification. Interesting example. The other thing that's interesting about osteomycutis is you can actually get bone marrow that forms in the middle of the bone. So you may even have a little bit of that bone marrow forming over here. Just kind of an interesting finding. You don't need to know necessarily much about that, but this is the bone marrow that's forming the little osteomycutis that developed in that mixed tumor. So hope this was helpful to you guys. For you third years that are on the call, congratulations on finishing your training. We will next month do kind of a lecture, an introductory lecture on dermatopathology. Welcome to Derm Path. Here's an approach to diagnosis. And then we'll start up with unknowns again in the following month.